about the evaluation of leg ulcer. So first, let's set the differentials. The common differentials are trauma, tumor, tuberculosis, and then you have to think about the other structures such as artery, then blood, then veins, and the nerve. So let's dive deep inside. In the arterial diseases, there are many diseases, but the common ones would be the peripheral vascular disease and the vasculitis. Blood disorders such as polycythemia vera, sickle cell anemia, and cryoglobulinemia. Venous disorders include varicose veins and deep vein thrombosis. And the nerve disorders or neuropathies may include diabetes, leprosy, and syphilis, although there are many other causes, but I have highlighted the common ones. So next, let's go through the clinical evaluation and then appropriate investigation. Obviously, in trauma, there will be a history of trauma, and we will not do any further investigations, no investigations at all, just review the patient. If there is a suspicion of tumor, then the history will include a rapidly progressing in size, and the raised age would indicate us that this patient might require a biopsy. And tuberculosis, there may be history of contact, there may be history of pulmonary tuberculosis such as cough. And if we examine the ulcer, there will be an undermined edge. And the investigations that we typically do are the sputum tests, such as sputum for AFB, MT, chest X-ray. And the arterial diseases, if the patient has peripheral vascular disease, the patient will typically have history of some risk factors, such as diabetes, hypertension, dyslipidemia. And he or she might have evidence of vascular disease in other sites as well, such as cardiac disease, stroke, and even renal disease. So the investigations that we should do are given the right side. For diabetes, we have to do the fasting blood sugar and 2 hours after breakfast. For lipids, we have to do the lipid profile. And for kidneys, we have the renal function test. When we take a detailed history of this patient with PVD, we might find a history of intermittent claudication where there is pain after walking some distance. There can be rest pain in the severe diseases, and in examination, there will be no pulse. And even if we examine closely, we might find features of peripheral vascular disease, such as atrophy of the skin, loss of hair, etc. In vasculitis, the patient will have palpable purpura and might also have evidence of renal disease or neuropathies. And for that, we have to do the NA and NCA. And duplex studies will help in both conditions, but more so with peripheral vascular disease. For blood dyscrasias, we have to take the classic histories, and the patient might have congestion suggestive of PCV and a vaso-occlusive crisis suggestive of sickle cell anemia. And if the patient has a hepatitis C virus, this might indicate a cryoglobulinemia. So we have to do CBC with ESR, and then we might also do cold agglutinin test. Venous disease, common disease is varicose vein, and another one is DVT. If the patient has varicose vein, the veins will be dilated and the leg will be swollen. And the typical location of the ulcer is in medial malleolus, and it usually has a sloping edge. And we can easily identify the disease by the duplex study, duplex ultrasound of the lower limbs. Neuropathies, in patients with diabetes, the patient will typically have history of diabetes. There will be reduced sensation, and the location of ulcer is typically on the heels and toes. In leprosy, the patient will have nerve thickening and patches of skin which does not have any sensation. Then syphilis, patient will usually have history of sexual exposure and some chancre. So for diabetes, check for diabetes, fasting blood sugar 2 hours after breakfast. For leprosy, do the nerve biopsy, and we might also do a slit skin smear to see the AFB. And for syphilis, do the VDRL.